Hello again, my name's Steve Campbell. Welcome to another one of my quick videos. On today's video, we're going to be talking about using long-term med codes versus substance use codes. I did a long-form video about this in the past, but we have had a recent change April 1st, 2026. Really, it doesn't change the video that much. Instead, all it is a change from an excluded 1 to excluded 2 note once when it comes to these Z codes here. What they've updated it to is now the excluded 1 notes that exclude F11.9, methadone use not otherwise specified, and F11.2, use of methadone for treatment for heroin addiction from being reported, with Z79.891, the long-term use of opiate codes. Basically, it just came down to how we use these codes, where we're going to explain this quite a bit further as we progress into this video here. So the guidelines for how coding works is we have these Z79 codes. These are your long-term RXs of medicine uses. These are medicine that a patient is actually on and given. The key one that I want to talk about is the long-term use of opiates, Z79.891. This code will get commonly mixed up with the F10 through F19, which are the substance use disorder codes. So let's talk about a couple examples of these, and let's decide together what we think is more appropriate. Patient presents with essential tremor, and they're complaining of high energy. Patient's currently using benzodiazepine, but finds it unsatisfactory and leaves them feeling high. The proper way of coding this is with a G25 essential tremor code and then the Z79.899 for long-term use of other medicines. An inappropriate way to be coding this is with the F13.90 for sedative use. This is a common issue in coding where people will use these use codes instead of the long-term med codes. This one up here on the top is actually my personal life story, and that's why I care so much about this one. Because I didn't know coding when I was just a regular person, and my health record had the F13.90 on it for a very long time. And it was incredibly challenging for me to get it off my health record, actually, because trying to get a drug addiction code off your record is just truly not easy. Rightfully so, it shouldn't be easy, because if I'm just someone trying to dodge my past, that's not great either. But providers need to know how to utilize these codes, so that way we're not misdiagnosing patients, and thus making it harder for patients to get the medicines that they need in the future. Another example is patient presents for pain management for long-term painkiller usage. They experienced a car accident in 2004, resulting in fractures of bilateral femurs and a fracture of the C4. Today they're complaining about worsening pain in both legs and their neck, opiates renewed. Proper coding would be to use this G89 for the chronic pain code that the patient's experiencing, and then we'll code the pain for each of the sites that they have. And then finally, we'll use personal history of their healed traumatic fractures, ending it with the long-term use of opiates. This is their RX of it. But instead, what providers will commonly do is this patient has been on opiates since 2004, and they have to continue to be on opiates. So they'll put opioid dependency. That's highly inappropriate, since opioid dependency is a substance disorder, meaning they're meeting the DSM-5 guidelines for opioid dependency. So be careful about how you label pain in addiction patients. I get it that these patients are dependent on them. I personally take SRIs. I am dependent on SRIs. I just can't quit them on my own. But to say that I have a dependency on them as a substance disorder is highly inappropriate. So just ask yourself, which one would you want in your health record? If you were the patient here at the bottom just complaining about pain, how would you feel if you knew opioid dependency was on your record versus long-term opiate use? If you were someone with essential tremor, how would you feel about someone saying you had a sedative use problem versus you used benzos because a provider prescribed them to you? Another case example that you'll see this happen commonly is a patient presents for ADHD management. They've been using Adderall now for 10 years and find it successful. Patient states reduce hyperactivity symptoms. How we would code this is F90.9. We would code it still with unspecified type. I get it, the provider says reduce hyperactivity symptoms, but we cannot actually code it as ADHD hyperactive type unless the provider explicitly says it. Then we'll use a Z51.81 code for the scenarios down here, where Z51 applies when the purpose of the encounter includes therapeutic monitoring of drugs, such as checking drug levels, toxicity, effectiveness. So let's say it's an Adderall patient where you're doing the routine drug testing just to make certain they're not abusing their meds, and then you renew their Adderall. Inappropriate way of coding it would be a F90.9 and then other stimulant use. That's a very bad code to say for this patient. That's implying a methamphetamine problem is usually what this code is for. Instead, it should be a Z79.99 or a F90.1. This is by far the best way to code it though, since we're going to be testing for levels. That's when we're going to want to use the Z51. But I get it, people will use these F10 through F19 codes because they'll be like, well, this F90 code doesn't cover a drug test. Correct, it's the Z51 that will cover the drug test. That's the code you want to use. And then we have a patient here on the right side here, case 4. Patient presents for polysubstance mat visit. They say methadone treatment has been successful. Their meth cravings are reduced and hasn't used in 3 months. Patient dependency on meth is showing improvement. However, they report continued abuse of marijuana and alcohol, and they also report occasional cocaine use. Proper coding would be a F15.20 for their drug of choice, the methamphetamines, that is currently dependency uncomplicated. We cannot use in remission because the provider hasn't directly said in remission. Instead, we will have to use this version of it. We will use cannabis abuse and alcohol abuse. Lazy coding, but you could get away with it, but it is lazy coding, is just putting on an F19 because it's polysubstance use. The polysubstance use is shown by the fact that this patient has 3 different drug codes listed on it. And finally, inappropriate coding for this one would be to code the cocaine use, because all we have documented is occasional cocaine use. That's not enough to support the substance use disorder, so I would recommend querying the provider to ask if they think it would be appropriate to use the cocaine use code. And let's just ask this question for this one. If you were reviewing a past record of a previous provider and now you're continuing the care for the patient, which one do you think tells the story of the patient better? The simple F19 code or all of the drugs for the patient? Personally, I think the top one, obviously. For the ADHD patient, do you think it's better to label them as a drug addict? Or do you think it's more appropriate to label them as someone who's just on an RX of Adderall? I think that one's quite obvious. So let's go through how documentation will affect these drug cases. All of these are the same patients. All these are the same patient is how I came up with it, but just different documentation. So let's go with documentation. Example 1, patient presents for drug addiction management. Their drug of choice is cocaine, and they also state daily cannabis and alcohol consumption. Patient states they will use meth when they can't get cocaine. Lazy coding is just throwing on that F19 code and calling it a day for the polysubstance. Proper coding would be to throw on the F14.20 for the cocaine dependency, and then you would have to query the provider for the cannabis, the alcohol, and the methamphetamine, because each of those aren't enough information to assign those codes. Let's say in the second scenario, patient presents for evaluation and counseling regarding substance use. Patient reports cocaine use as their preferred substance. Patient also reports daily cannabis and alcohol use, and reports occasional methamphetamine use when cocaine is unavailable. Now we're getting better there because we have the use reported each and every single time throughout. It's not just simply daily consumption. The provider's actually utilizing use in their statements. So now we can get away with assigning all of these additional drug codes for it. But what would be the best way to code it? Because obviously this is just use now. which isn't that great because use is the best word used throughout this sentence. An even better way to say it would be column 3 here. This is where a problem-based charting can be such a great way of coding. Of documentation, because that way it makes your coding more robust and more appropriate when you get audited. Patient presents for management of multiple substance use disorders. We have a line for cocaine use disorder, severe, active. Cocaine is patient's primary drug of choice. Patient continues to use cocaine when available. No current intoxication, withdrawals, or cocaine-induced disorders. Cannabis use disorder, moderate, active. Patient reports daily cannabis use. Alcohol use disorder, moderate, active. Patient reports daily alcohol consumption, no current intoxications. And finally, methamphetamine use. Now, as you see, we can actually use cocaine dependency, cannabis dependency, and alcohol dependency. All these are obviously HCC codes, and it tells the story quite a bit better. So, once again, which version do you think tells the patient's story better? This is why it's so important that you document as much as possible. If you are the provider, your role is to document the story as much as possible so then your coders can pull out the code. Coders, your job is to review the record to the entirety so we can code it to the highest level. And don't be lazy and just use F19 codes. Yes, you can get away with it, but which one do you think tells the patient's story better? This one single code or these 4 codes with actual applicable statuses? And finally, I have a version of alcohol that I hope will frame the story of how coding will work. Bad documentation. Let's say we have a chart that reads, patient presents clearly drunk. They report they drink a flask of vodka twice a day and a 6-pack of beer as well. Obviously, as a layman, I'm very aware that that patient has an alcohol dependency issue. We're all aware of it. However, as coders, we are not allowed to assume, and we are not allowed to code off of purely clinical indicators. Instead, we have to code off of the record itself. So actually, this chart here wouldn't actually give a code at all. You would have to query the provider for it. There's not enough information here at all. A better way of saying it is a patient presents for evaluation of alcohol dependency. Patient reports consuming approximately 2 flasks of vodka a day and a 6-pack of beer. Patient has alcohol dependency with ongoing daily consumption. Since the provider is directly stating it each time, we can now code it. And obviously, we knew the patient was intoxicated. We knew the patient had a dependency issue, but we really couldn't code it with this record here. Because as coders, we cannot use clinical indicators. We can only use a provider's direct, explicit language. But let's do an even better documentation, because this is where I think people miss the most on their documentation, is there are DSM-5 criterias for these alcohol use disorders, every use disorder. Personally, I don't see it enough in records, and I would love to see it more, so I wrote it as a way where it would be the provider did all that. So patient meets criteria for alcohol use disorder, severe alcohol dependency. Patient reports the blah, blah, blah. We've all read that plenty of times. The patient reports inability to reduce alcohol intake. Despite attempts to quit, their tolerance is increasing. They have cravings. They have withdrawal symptoms. Everything's written so in that way we have at least over, 5 criterias to hit the dependency. And that's it. That's how we'll code it. So the best documentation supports dependency more at the bottom here. Why? It's because the documentation specifies dependency indicators, such as his ability to cut it down, tolerance, craving, withdrawal symptoms, and continued use despite negative consequences. So finally, to wrap this one up, basically what I want the takeaway for us to be is be careful when you're using a substance use disorder code when instead a Z79 is going to be more appropriate. And then when you are using a substance use disorder or abuse or dependency, make certain you tell the whole patient's story so that way you're avoiding lazy coding and you're coding to the highest level. And finally, once again, to more or less reward you for doing it that way, is remember these are all HCC codes, so why would you report only one HCC code when you can report 4? My name's D. Campbell. Thanks for watching one of my videos. Have a wonderful day. Bye now.